Good afternoon, everyone, and welcome to this new presentation in our Institute for Global Health Sciences COVID-19 series. Today, I will be the speaker, and I will be talking about the new plague. What lessons have we learned? Just as a reminder, we will continue this COVID series mostly on a bi-weekly series, on a bi-weekly timeline, but we will also have some grand rounds in between. I will announce the next coming presentations towards the end. And also a reminder that the opening for the PhD in global health is coming now, and I will announce that also towards the end. So let me now share my slides and talk about the new plague. So as you can see, the plague has been present in art and in literature for a long time. So what I will do is to present here some of the highlights of pandemics in history, a little bit about pandemics in literature, then something around the global and local epidemiology. I'll review very quickly scientific progress around tests, treatments, and vaccines. I'll talk a little bit about vaccine equity, and then focus more on public policies. What works, what doesn't, what are the successes, what are the failures, what lessons have we learned? So in this timeline of the history of pandemics, we have here the chronology, the evolution in time, while in here we have the different pandemics humanity has suffered. Just to mention that the size here reflects the magnitude of the mortality. And you will see that by far the most mortal of all previous pandemics was the Black Death that affected Europe in the Middle Ages in the 14th century and covering more than 200 million deaths. Then the more recent one, of course, is COVID. But how does COVID compare to previous pandemics in terms of magnitude? We can see that in here. As I said, by far, Black Death has been the most lethal of all pandemics in history. But there are others, like the smallpox that essentially devastated Native Americans in the 16th century. So I was explaining the outline. I was mentioning how different pandemics have had an impact on mortality, being the Black Death, the worst of all in the 14th century, how smallpox decimated the population of Native Americans, the wrongly called Spanish flu epidemic of 1918. So these have been the most lethal of all pandemics in history. Relatively speaking, COVID-19 is less lethal in terms of total number of cases so far compared to other pandemics, but still a very, very serious one and growing. It is estimated that it might double in size by January 1st, 2021. Now, how have pandemics impacted world developments in history and in politics? In 1918, President Wilson was attending in Paris the negotiations, the peace negotiations after World War I. Here he is with the Prime Minister of Italy, Lloyd George, Prime Minister of England, George Clemenceau, Prime Minister of France, and President Wilson. Well, Clemenceau and Wilson had a major dispute about what kind of sanctions should be imposed on Germany. And the fact is that when Wilson fell ill, essentially he dropped all of the negotiation. Clemenceau won, the Treaty of Versailles was signed, and Wilson had a stroke a few months later and essentially was an ineffective president after that. In terms of pandemics in literature, I have been rereading some of the books. This is Daniel Defoe, who, as you know, wrote Robinson Crusoe, but he also wrote this journal of the plague year in 1665. This is a very detailed account of the impact of the plague in London. Very good reading. Of course, one of the most famous pieces is The Plague by Albert Camus in the 1940s. The plague taking place in Algiers. Fascinating description. I highly recommend it. And of course, Gabriel Garcia Marquez, Love in the Time of Cholera, is a must-read, a beautiful description in the early 20th century of cholera in South America. And more recently, I reread this book by Philip Roth called Nemesis, describing the polio epidemic in the US. This is actually autobiographical because in New Jersey, where he was born and raised, there was a huge epidemic of polio while he was growing up. Let's take a look at the epidemiology. This is the Johns Hopkins chart you're so familiar with. 35 million global cases. This is probably an important sub-estimate. It is mentioned by WHO that 10% of the population might have been infected by now. Over 1 million global deaths, with the US, Brazil, India, Mexico, and the UK on the top 5 countries in terms of number of deaths. Now, if we look at cumulative incidence in a global scale, it is the American continent, South America, North America, that account for over 1/2 of the deaths already taking place. And if you see in this map, again, it is the American continent that concentrates the largest number of deaths, while in Europe, Spain, Italy, Sweden, and the UK contributing as well. Now, this is an interesting graph. Not too many people know that in terms of deaths per 100,000 population, Peru is the one country that by far has the largest mortality rate per 100,000 population. And it is 3 Latin American countries that have also the highest number, with Spain and the US coming along. Now, in terms of how many deaths per case, what is known as case fatality ratio, Mexico is now number 1, with the UK, Iran, and France coming next. Another thing to consider is that not all deaths due to COVID are the only impact. There are also indirect consequences, what is called as excess mortality, deaths that are not necessarily due to COVID but by other causes. And the number of deaths are sometimes twice as many of the normal epidemic curve of previous years. So it's estimated that over 300,000 deaths have been not counted or missing, which is a reflection of the true toll of excess mortality. Mexico, Brazil, Peru, Ecuador, again, mostly in Latin America, Bolivia, are the countries with the largest excess mortality. Now, what about new cases? Well, it seems that Europe is suffering a very acute second phase. And in terms of number of new daily cases, Spain is now at the top, followed by France and the United States. You could say the United States is now in a third wave. Applies also to the UK, while other places in Latin America seem to have a slightly lower daily number of cases. Now, how aggressively are countries tracing and testing? You can see that in New Zealand and Australia, the number of tests done per confirmed case is amazing. 600 tests per every confirmed case. That is a reflection of how aggressively New Zealand or Australia or Taiwan are trying to find cases and test them and isolate them, while other countries that cannot afford the test or for whatever reason are doing very little testing. This is a graph that appeared in the last issue of The Economist, which I found very interesting. So Europe is facing a second wave, but it is not as bad as the first wave in terms of mortality. While the number of cases are now greater than in the first wave in March and April, the number of deaths relative to the cases is relative to March and April, is much lower. Now, they are doing much more testing now. If you did apply the number of tests done in September to the cases in March, you will see that there were very many other cases in the first wave that were not counted because of lack of testing. So the second wave in Europe is much less aggressive than the first wave. You can see here that the number of tests performed per week from March to September has increased enormously. Confirmed cases who passed away, much lower. Tests that were positive, much lower. Survival among those that were hospitalized, much better. So bad as it is, the situation in Europe, is not as bad as the first wave. This is a study in different places of antibodies, just to get a sense of how many cases were missed. So these are in red national surveys and in gray regional surveys done in India, Russia, US, Nigeria, Sweden, Spain, England. So the point here is that the real number of cases to confirm cases is much greater. In India, 270 times greater. In Nigeria, 1,600 times greater. And even in the US, it's estimated that the real number is 7x. And again, this is showing excess mortality in different regions. This is a map recently posted in the New York Times showing that the cases in the US are now mostly taking place, new cases, in colleges, in counties that have colleges and universities. And the dark dots are colleges that have more than 1,000 cases to those that have fewer than 10. In California, Cal has reported over 200, and UC San Diego is actually the one UC campus with the largest number of cases. Now, this is a very busy slide, but I find it fascinating. This is the UCSF health dashboard. It's updated every hour, and it tells you with exquisite detail how many patients are currently hospitalized, how many are in acute care, how many are in critical care, how many have been vented. Point is, there has been, unfortunately, 19 deaths occurring of the over 400 hospitalized. This is the lowest proportion in any hospital in the US. And it provides the origin of the cases, it provides the positivity test. So by all accounts, we're very fortunate at UCSF and in San Francisco to have one of the lowest cases and hospitalized patients in the country. What about scientific progress? Well, there are two kinds of tests, molecular and serological. Molecular serve for clinical individual diagnosis. You know about PCR, and increasingly antigen tests are being done. This is what is performed daily at the White House with some problems. It's estimated that it might miss 1 out of 3 positive cases. They're getting better, and there are a number of brands from Abbott to Roche and others improving, but they are still not as reliable as a PCR. Of course, have the advantage of being point of care and fast, but not as sensitive and as specific. So these are mostly for individual diagnosis, but also for contact tracing. That is different in serological tests that have the purpose of estimating population prevalence. You can identify either IgM or IgG. Those appear anywhere between 1 to 3 weeks after symptoms and might reflect temporal immunity. Now, these antibodies wave after a few months, so they are not necessarily very, very reliable for point prevalence after a long time after infection. In terms of scientific progress in therapy, it's pretty amazing that in such a short time, at least 3 lines have proven very successful. These were therapies instituted to President Trump, as you know, monoclonal antibodies. Regeneron provided a polyclonal antibody. This has not been officially registered and approved by Food and Drug Administration. It's used on so-called compassionate case, but this is clearly the future of treatment. Expensive, but quite effective. Remdesivir serves to impede the replication of the virus and shortens hospital stay. It has proven to be effective. And dexamethasone, a steroid, serves to regulate inflammation and decrease the potential problem of cytokine storms. There are other therapies that are less effective and some others that are still experimental, like the nanobodies you have heard in previous presentations. Labs developed at UCSF, which are mini monoclonal antibodies called nanobodies that seem to help in preventing infection when used prophylactically as a spray. Now, how many vaccines are under development? This is from the New York Times. There are many in phase 1, phase 2, phase 3, and some have even received limited approval. Now, let me explain a little bit more these vaccines. Some are the ones that were more familiar, developed in the US or in England. These are vaccines that are in phase 3 that have not yet been approved, while the ones that have been approved for limited use are Chinese and Russian. And my concern is that these approved for limited use might have cut corners in terms of safety. And I also think that there is a possibility that we might have a different allocation of vaccines based on geopolitics. Perhaps the Chinese vaccines being more used in Asia, while the American, European vaccines more used in the West. So that is a concern I have, and we just need to make sure that all of the vaccines really comply with safety and efficacy protocols. In terms of vaccine equity, there are impediments for global vaccine allocation. And I list just a few: political, economical, supply, and then hesitancy. What are the impediments in terms of politics? We have seen already that there are nationalistic attitudes, America first, with control of exports, and a wrong attitude towards poor countries, so-called the shithole countries, that might prevent poor countries from benefiting if we listen to President Trump. Also, the US and some European countries have already allocated billions of dollars in what is called anticipated purchase agreements to vaccine producers in a bilateral agreement so that more than 1/2 of the estimated production of vaccines have already been allocated to wealthy countries. And we have had examples of nationalistic attitudes in the past with H1N1 vaccine, and also with PCR tests and with remdesivir. So I worry that countries that produce vaccines might want to serve their own populations first before sharing any surplus. In terms of allocation, there are two recent examples of frameworks, one for H1N1, where pregnant women and kids less than 6 months of age were given priority, and health workers coming then. While in Ebola, the preference was to create some kind of a perimeter, a ring of vaccinations so that the disease would not spread. And then second priority was frontline workers, and finally local mass vaccination. So there were frameworks that helped in the past. Nowadays, what about COVID vaccine allocation? Well, the National Academy of Medicine just released a report with certain criteria. And the criteria focused on people who are at the highest risk of acquiring infection, frontline health workers, nursing homes. Second, what populations are at larger risk of having a severe consequence after infection, and so forth. So these are criteria based on priorities. The WHO came up with a model for low and middle income countries that might not be ideal. They propose in a phase 1 begin with 3% of a country population, and subsequently incremental doses until 20% of the population is reached. Problem is that countries that, say, China, having a vast population, 3% is a lot of vaccines, and they might not need it because they don't seem to have a problem. So these criteria, strictly based on population, might not be ideal. They have another model, Model B, where countries would receive doses of vaccines according to how many frontline workers they have, what proportion of their population are elderly, how many have comorbidities. This model has also been criticized because very poor countries might not have enough frontline workers or might have mostly young populations, and they might be castigated as a consequence. Fortunately, there is an alliance called COVAX, the COVID Vaccine Global Access, that is an alliance between Gavi, WHO, and CEPI. CEPI is a coalition for epidemic preparedness innovations. This is a body created in 2017 that is providing the funding for research of new vaccines, while Gavi is taking care of the distribution of vaccines. So many countries have signed the COVAX agreement, and they will benefit in receiving vaccines as a consequence, but again, not necessarily in sufficient numbers. What about public policies? What are examples of successes and failures? Well, one blatant difference is Norway and Sweden, which, by the way, were one country in the 18th and the 19th century. So they have vast differences in terms of public policies. only 274 people have died from COVID in Norway. And Norway is doing vast number of tests, while many, many more people have died in Sweden, which have had a laissez-faire approach and very little testing. So the fatality rate in Sweden is almost 12 times larger than in Norway. So two neighbor countries, very similar in culture, very different in terms of public policies, and the impact is visible. I took these graphs from a Lancet recent paper comparing public policies in 9 countries, some from Asia, some from Europe. So we have Germany, Hong Kong, Japan, New Zealand, Norway, Singapore, South Korea, Spain, and the UK. Asian countries started with lockdown, controlling movement, and imposing that strictly early on, while Europe did to various extents later on. You will see that when the control of movement was eased, it started first in European countries, and they became a little complacent. There are also important differences in terms of how strict the lockdowns were and what other measures for physical distancing were. From 1 to 2 meters, Asian countries being more strict in mask wearing, more strict in reopening schools, and importantly also in the contact tracing tools. Asian countries took more strict measures for contact tracing, including Bluetooth, including face recognition with cameras, or even credit card transactions. Perhaps those measures would be less easy to impose in the West, but what is unquestionable is that those measures were effective in controlling chains of transmission. If you look at the impact in those 9 countries, you will see that countries in Asia had 3 logs or more less deaths than countries in Europe. And this is 3 logs, this is 2 logs compared to the United Kingdom or Spain. So public policies, how early and how aggressive you impose those has a huge impact in mortality rates down the road. Now, don't let me even get started with irresponsible public policies. This is what we saw in the Rose Garden on September 26. People not wearing masks, people not having physical distance, with the consequence that 12 people so far have tested positive out of that event. Or this is a picture of the presidential debate where the family of Mr. Trump decided not to wear masks in spite of the ordinance to do so. So that irresponsible behavior has had consequences in terms of what is now considered a super spreader event. Now, I'll finish now with how political leadership and attitudes have a huge impact on the epidemic locally. Populist presidents or prime ministers like Boris Johnson, López Obrador, Bolsonaro, Donald Trump, Putin, Modi, just look at the angry faces, look at the finger pointing, blaming others or minimizing COVID and its risks compared to countries that have been highly successful, like Taiwan, New Zealand, Norway, Germany, countries that are led by women, and frankly, in a much more effective way in terms of COVID impact. And by the way, they're all smiling as opposed to angry. So what are the lessons learned here? COVID-19 is not the first, and it will not be the last pandemic. We need to prepare seriously for future pandemics. COVID-19 has been a stress test for health systems. We ought to make sure that we have better surveillance systems that find, test, trace, isolate, and support people infected. We need to invest in surveillance much more aggressively. It has been finally recognized by CDC and WHO that it is not about droplets, but also about aerosols. So COVID can be transmitted airborne. And this is one more reminder of the importance of masking. As we have seen, impressive scientific progress in 10 months. And I'm very optimistic that we will have effective and safe vaccines sometime in 2021. I want to make the point that allocation of vaccines when we have COVID vaccines need to have a global scale, and not only for humanitarian reasons, but also for national security reasons. As long as there is COVID somewhere, nobody is going to be safe anywhere. As we have seen, early and aggressive public are more successful and have a much better impact in preventing chains of transmission. And my final thought is beware of populists, and hopefully we will have more women leading countries because clearly we have seen the positive consequences. I'll stop here and I'll thank you for your attention and apologize for the technological problems with showing slides at the beginning.
Thank you, Jaime. Hi, everyone. I'm Kemi Amin. I'm the Communications Director for the Institute for Global Health Sciences. And I have a few questions to ask you regarding your presentation. The first being, what would be an ideal diagnostic test? Should we consider something like a mail-in hormone test or an at-home pregnancy test?
Well, clearly, PCR testing, molecular testing is optimal in terms of sensitivity and specificity, but it takes hours to run the test, and there are delays sometimes of days to get a result back. So the utility of having that might not be as much in terms of preventing infection to others. So ideally, having some kind of a pregnancy test where you could test yourself at home would be ideal. So that obviously would not be a PCR because you cannot have a PCR machine at home, but having an antigen test that is highly sensible and specific would be ideal. So again, just like a pregnancy test you can do at home, that would be perfect. And it is possible that we will have tests done in saliva that won't require a nasal swab sometime soon.
Mm-hmm. And just as a reminder for anyone who is still on the call, you can drop your questions in the Q&A section. And then I have a second question here for you. What do you think about President Trump's treatment of COVID?
Well, he obviously was hospitalized in a top-notch hospital. The Walter Reed is a military hospital, superb, famous for their research in infectious diseases. So he had the very highest possible quality of care. Now, he was given access to monoclonal antibodies that are not available for you and me. If I fell very ill tomorrow, I wouldn't be able to get a Regeneron polyclonal antibody if I wanted. So it shows the issue of inequities in terms of quality of healthcare. But of course, he is the president of the US. Understandably, he received the very best treatment. Was that too aggressive? Some doctors say that it was throwing the whole sink, the kitchen sink, to him by having remdesivir, monoclonal antibodies, and dexamethasone within 3 days. So hopefully he will recover fully. I wish him the best, and the First Lady and all of the rest of the people that got infected. It shows inequalities in healthcare, and some people say it might have been excessive treatment that is without some dangers as well.
We have a question here from a viewer. Would you say the upbeat surge of energy resulting in the, quote, "I feel better than I felt in 20 years," end quote, a result of steroid euphoria from the dexamethasone? And how much danger is there from the burst of energy while still very infectious? And should the president's medical staff be stepping in?
Personally, I think it was highly responsible, because clearly he's still infectious, and going out in the car put the Secret Service people at risk. That is a very closed, armored vehicle, and that was irresponsible. Cortisone, dexamethasone, has the consequence of making you feel very good. So in the first few days of receiving dexamethasone, you are in very high spirits. So that might explain some of his attitude in saying, I feel better than 20 years ago. It might be an indirect consequence of the medication he's receiving.
Interesting. We have another viewer question. What is the current status or utility of antibody testing?
So antibody testing is very useful for measuring prevalence, point prevalence, what proportion of the population have been infected at this moment in time. And it's not perfect because, as I said, antibodies tend to go down. So a few months after, you might not be able to detect antibodies even if you were infected. It doesn't necessarily mean that you are no longer immune, because there are two kinds of responses: cell-mediated immunity, antibody immunity. So even if antibodies fall down, you might still have cell memory. But in terms of the utility of antibody testing is to learn if you have been recently exposed to the virus. So in that sense, it's important for population studies.
Got it. Another question is, do you expect that different parts of the world will receive different vaccines according to their geopolitical position?
I did mention that, and I think it is a real possibility. The Chinese will certainly aggressively sell their vaccine as the best because there is a vaccine race. There is a prestige associated with being the first one that comes out with a powerful vaccine. So I'm sure there will be geopolitical interest in having my vaccine applied in this continent, or I will give you my vaccine cheaper, or I will give you my vaccine for free. So it will also serve a diplomatic purpose. So I'm glad there are many platforms being developed. I'm glad we have so many vaccines being tested and reaching phase 3. My hope is that everyone that needs a vaccine will get it sometime in the course of 2021. And we need to work very, very hard for that, because it's not only the vaccine. Remember, it is the needles, the syringes, the vials, the cold chain, and the health workers to apply. We're talking about 11 billion doses, unprecedented in history in terms of supply chains and implementation sciences. It will be really complicated, and I'm not sure countries are up to the game yet.
Yeah, it'll be interesting to see how this develops further. If you have any questions, again, you can drop them in the Q&A. In the meantime, I'm going to share a slide about the PhD program.
Oh, thank you for doing this, Kemi. Just a reminder for everyone watching that we are currently accepting applications both to the Master of Sciences and the PhD programs. So please distribute this to whoever might be interested. The deadline is December, so please help us distribute this news about currently accepting applications for both our graduate programs in global health.
And just to close us out, we have one more question here that we have time for. So what part of the supply chain do you expect to be the rate limiter for vaccine distribution, e.g. production, storage, last mile logistics?
So I think we have in the critical path several impediments. Production, I think most of the current platforms are aiming to be able to produce up to 1 billion doses in 2021. So if you think there might be 3 or 4 successful vaccines, we might have maybe sufficient doses to cover the critical populations described in the National Academy and WHO guidelines. So production is a question mark, but maybe not the main one. I think it's mostly about the cold chain. Some of the vaccines, like Moderna, needs an ultra freezer, minus 70 degrees centigrade, and not many countries have that kind of cold chain. These are very, very expensive ultra fridges. So I think it's more in the cold chain distribution and also on the health workers. We need to train and recruit a lot of health workers in order to be able to apply 11 billion doses in 1 year. So this is unprecedented. Never in the history of vaccine campaigns such a vast number have been attempted. So that is my main concern. Not so much in production, but on the distribution and implementation.
Mm-hmm. I actually had a final question about LMICs. Are there any examples of countries that you think are doing things right?
Oh, totally. I think the examples of Taiwan, New Zealand, certainly Norway, even Singapore that had a second wave are countries that are doing very, very well. Hong Kong is doing very well. Of course, those you could say, well, are small countries or are islands or have this characteristic. But the fact of the matter is that many of those are led by women, and they have been imposing more aggressive and early public policies than the rest. So I think those are the lessons we can derive of acting early and aggressively, with several examples, as I have mentioned.
Great, thank you. And we have one more question that just came in. San Francisco is led by a woman who was willing to be aggressive at the cost of her career if necessary. So
yes. I have tremendous respect for Mayor London. San Francisco, I think it's an example of having imposed very early restrictions in movement and recommending confinement and recommending mask wearing. So I think we're lucky. And even within California, if you compare San Francisco or LA, you can see differences in public policies and as a consequence, differences in infection rates and mortality rates.
Okay, I think we have time for one more question here. So a paper-based COVID-19 test kit has been developed in India called Feluda, F-E-L-U-D-A, and is supposedly set to be made available soon. Have you heard about this new test and have any thoughts or opinions on its accuracy or true ability to be available soon?
I'm sorry, I don't know about this specific test. I would love to learn more. But my prediction is that in the next coming months, we will have tests that are cheaper, more reliable, and being able to be done at home. So I think progress is fantastic in terms of science, and many of the discoveries will be applicable to other health conditions as well. So that's exciting and much needed because we are in a very dire place right now.
Great. I don't see any more questions coming in here. So thank you, Jaime.
Just a reminder, on October 15th, which is a Thursday, not a Tuesday, we will have grand rounds with Dr. Gillis Walker, which is about transforming the culture of care. So please put in your calendars October 15th, grand rounds. And then on October 27th, we will have Dr. Monica Gandhi talking about masking and mortality. So thank you for your presence, and I will see you in the next grand round. Thank you so much and have a safe day. Bye.